Well, hello everyone, and welcome to the 6th session of the Keep Thriving Wellbeing Conference 2022. My name is Stephen Cook. I'm Head of Policy and Communications at the British Safety Council, and I'm your chair for today. In this session, we will hear from Stephen Bevan on the subject of good work and good health, what the evidence tells us. So I'm going to welcome Stephen now. Stephen Bevan is Head of HR Research Development at the Institute for Employment Studies, that's the IES. And Stephen is currently leading projects on work after lockdown for the ESRC. He's principal investigator of a major DWP-funded research project to assess the impact of job support for people with depression, and a major programme of work looking at obesity stigma in the labour market. He's co-investigator at the Centre for Musculoskeletal Health and Work at Southampton University, and was an expert advisor to the UK government's Thriving at Work review of mental health and employment. He's recently published a book with Professor Carrie Cooper called The Healthy Worker: Enhancing Wellbeing and Productivity in the Workers of the Future. So without further ado, Stephen, over to you.
Thank you very much, and thanks very much for the invitation to speak at this important event. Just a bit of tiny background about the Institute. We were established in 1969. We're a charity. We have about 45 multidisciplinary staff. We carry out applied research and consultancy on all different aspects of the world of work, and I take a lead in our work on looking at the health of the working age population. And we've been working most recently with Mates in Mind on a project looking at the mental health of self-employed construction workers. I'm going to tell you a little bit about that later in my presentation. And to be really up to date, last week we published a new survey project looking at return to work after cancer. And that's especially relevant to me, as in the last 2 years I've with myself returned to work after some intensive treatment for cancer of the esophagus. So I'm my own case study. So today I want to explore the ways that job quality, decent or good work are linked to good health in the working age population. Can we have the next slide, please? And I want to explain a little bit about why policymakers, healthcare professionals and employers need to weave the principles of good work into the way they do business. So I suppose my core proposition is to assert and hopefully back up with evidence that good work and health are linked together. What I want to do to start with is to look at this concept of the social gradient. And I think it's an important way of helping to explain why this link exists. If we go to the next slide, we can see a very simple graph or chart which helps explain this concept. So there's been a lot of focus, particularly through the recent announcements around levelling up, but obviously for some years before, on health inequalities. And obviously, inequality of health outcomes is quite an important aspect of policy and practice, and health outcomes vary considerably depending on your position in the social gradient and where you live. Look at this simple diagram. This is a representation of the Central Line on the London Underground with Lancaster Gate, which is a tube station in West London, Mile End, a tube station in East London, and the average journey time is 20 minutes between the two. And as you go through each stop on the Central Line between those two stations, the life expectancy on average of the population living by each tube station drops by a total of about 12 years. Now that's a really significant difference. It's explained by a basket of factors such as education and housing, environment and employment status. But the social gradient isn't just about mortality, it's also about morbidity. There are lots of factors affecting morbidity. They can be things like depression or coronary heart disease or obesity or chronic obstructive pulmonary disorder. The fact that many more people now living as they age with multiple chronic conditions is having an impact on this. Let's go to the next slide, where I've got perhaps a more topical example, particularly given that we yesterday had the announcement of the nominations for the Oscars. This is a slightly frivolous piece of research, but nonetheless illustrates the same point, that Oscar winners people who won Oscars had an average life expectancy of 4 years longer than those people who were nominated but didn't win. Now that is an example of the health benefits of your position in the social gradient, perhaps. and there's a reference to that study at the end of the presentation. I suppose my question is, are we hitting upon a deeper truth here about the way that people's position of the social gradient affects their well-being, and what role does employment and the workplace play in all this? If we go to the next slide, we can look at some of the evidence that's been gathered over the years, actually, by Professor Sir Michael Marmot and his colleagues at the Institute of Health Equity. Can we have the next slide, please? In the Whitehall 2 study, which is the second cohort study carried out in the 1980s, that were tracking health outcomes of over 10,000 civil servants. And what this chart shows is that your mortality, so your risk of dying, it varies considerably according to what type of role you had in the civil service. And the bottom line is it showed that the mortality rate of men in the lowest grade, so in these support grades, was 3 times higher than those in the senior civil service. So there's something going on there about your position in the grading structure, the position in the hierarchy, even if you control for factors such as smoking. Now, if those differences can't be explained by lifestyle factors alone, the researchers asked the question, is there something intrinsic about the work itself that helps explain grade differences in health outcomes? Let's look at the next slide. And when the research team delved a bit deeper into this, they found that when they were looking at just one health condition, this is coronary heart disease, the level of control that people had in their jobs seemed to make a significant difference. And they found similar results for depression and anxiety. So the risk of coronary heart disease was considerably lower for people who had high levels of control in their job. Now, there's all sorts of implications of this, not just in terms of public health, but also for employers. There's a powerful indicator, I suppose, that employment status and specifically job quality and good work is an important economic and social determinant of health, out of several others. If we go to the next slide, you can see the array of other things that have been identified as social determinants of health. Employment is one of them. Education, housing, childhood experiences, access to health services, family income, and so on are all other factors. And it's really important that we recognise that access to good quality jobs is not just a good indicator of where you stand in the social hierarchy and your risk of developing chronic health conditions, but it's also something that public health people ought to be interested in, as well as employers. Now, this work that was conducted by Professor Sir Michael Marmot and his colleagues has been really vital in helping us to understand the science behind the assertion that good work is an important contributor to good health. Let's take a look at what this might mean in workplaces on the next slide, please. And specifically the implications for work organisation, job design, leadership and culture and so on. These are generally accepted to be the components of good quality work. Job security, where it's possible to deliver varied and interesting work, autonomy, control, ownership and task discretion, fairness in the workplace, a balance between the effort you put in and the rewards you get back, and that's not just financial rewards, opportunities to learn new things, to grow and develop and use your skills, a voice in the workplace, and strong working relationships. All these things make a contribution not just to the quality of work that people get access to, but the drivers of good performance, staff retention, and so on. And if you go to the next slide, we can see a number of echoes, I suppose, and the language is very similar. If you look at the Health and Safety Executive Stress Management Standards, which have recommendations, I suppose, for the way we manage psychosocial risk assessment and psychosocial health at work. But it would be a mistake, I think, to assume that the only reason that employers should focus on job quality and good work is because they want lower sickness absence or presenteeism or fewer accidents. There are many other benefits as well to having high levels of job quality. If we go to the next slide, it's pretty clear from all the other research in the sort of human resource management field that the good work principles set out in the last couple of slides inform good HR practice. They inform good quality line management, good communication, good job design, giving people opportunities to do jobs which are fulfilling, rather than just boring or routine. And that good health, high levels of discretionary effort, high performance and good retention rates are byproducts of good work. So one of the most helpful ways of thinking about these issues at the level of the individual worker and the teams they work in is what's called the job demands and resources model, which you can see on the next slide. So here you can see on the, I suppose by thinking about the physical and emotional demands of a job and the personal and organisational resources and support available to them to draw upon, we can use things like risk assessment, job redesign, changes to work organisation to reduce employee exposure to intolerable or unsustainable work demands, which may damage their well-being. And organisations like the OECD, for example, use this model to identify at the level of workforces across their membership, the levels of job strain, for example, that may be being experienced in different countries, in different sectors, by different occupational groups. And I think this is quite a useful way for HR people, occupational safety and health professionals also to think about the way they look at the chances of people at work developing, for example, mental health related issues, if the demands of their job on the left-hand side aren't matched by or supported by the resources that people have to draw on the right-hand side. If we go to the next slide, please. Steve mentioned at the beginning the work after lockdown research that I'm involved in with colleagues at Southampton Business School. We've been doing surveys of people working from home. And what we found is that both mental health and productivity seem to be higher amongst employees who are reporting high levels of control, autonomy and task discretion. So many of these elements of good quality work seem to be paying off in terms of people's mental well-being, their psychological resilience, but also how productive they are. And this slide shows some of the answers to some of the questions we've been asking them at a more micro level or a task level, which are strongly correlated with self-reported productivity and with good mental health. So being able to make your own decisions about how to schedule your work, being able to decide on the order in which things are done in your job, being allowed to plan how you do your work, using your personal initiative or judgment in carrying out the work, or being allowed to make decisions on your own, are all at a micro level components of this autonomy and discretion and control, which the wider epidemiological research has been shown to be strongly related to psychological well-being at work. In fact, the data on productivity and mental health whilst people have been working at home have been pretty striking. If we go to the next slide, please. Here we've got a simple graph that sort of illustrates the point I was making just now, that we've been using the WHO 5 measure of mental well-being, which is a very simple 5-item measure of mental health. We found a really strong relationship between people, between mental health and productivity. So along the bottom, you've got the extent to which people saying they get more or less done in their work since before the lockdown, for example, and their mental health score. And the mental health scores for the most productive workers were twice as high as those with the lowest levels of self-reported productivity. So among other things, these findings have got implications for how we support managers to manage remote teams, because an insight into how this dynamic between social support, discretion and autonomy in their jobs, mental health and productivity are really important for managers who are managing remote teams to understand and perhaps to adapt their style, for example, the way they communicate. The second thing is that this whole issue about working from home sadly has become rather binary. Sometimes the debate about whether people should be allowed to go back to work in a hybrid way, sometimes at home, sometimes in the office or in the workplace, has got slightly politicized, unfortunately. And of course, the truth is really hard to pin down, because for some people, their well-being is better if they're in the office, and for some people it's better if they're working from home. In general, I'm seeing lots of organisations trying to come up with some sort of hybrid model that allows them to think about different tasks in people's jobs that may be better performed collectively in one single workplace, whereas others may be better performed at home or remotely. But I think that the argument that working from home is always bad, always good, needs a bit more nuance. But our findings suggest that for many people, working from home hasn't had a big negative impact on productivity and can be positive for mental well-being. Of course, that's not always true for everybody. If we go to the next slide, I suppose the next question is, of course, the people who've been working from home are relatively privileged. They tend to be in white-collar roles, more senior professional technical managerial roles, not exclusively. But of course, there have been lots of people who've been unable to work in those sort of environments, particularly frontline and key workers. The other group that's often ignored in this type of debate is the self-employed. Now, we have seen quite a drop in self-employment during the pandemic, but on the face of it, you would think that self-employed people and entrepreneurs have lots of autonomy, lots of control, lots of discretion. They're masters of their own destiny, and that's partly why they choose self-employment or to work as freelancers. I think the evidence here is pretty mixed. There are some studies that show that some self-employed and freelance workers enjoy considerable autonomy and better mental health. But there are others that show that self-employed people and their work can be much more stressful. They have less control than they anticipated, and also they're in relative isolation. So I think this is a group which is potentially at high risk, partly because we don't know very much about them, or we're not routinely collecting data and understanding the challenges they're facing, which makes the piece of work that we're currently doing with Mates in Mind particularly important. If we go to the next slide, please. We've been looking with our colleagues at Mates in Mind at self-employed construction workers in the UK. We know from the evidence so far there's quite a high prevalence of mental illness amongst construction workers, and up to 3 times the national rate of male suicide. So this can get quite serious, particularly given that many of these people go under the radar. They're not sort of naturally part of the sort of surveillance that we do of people at work, and they're quite elusive in terms of monitoring their well-being. And our study has involved so far a survey. We've collected data so far from 300 people in this category, and we're now doing some follow-up interviews to gather some more case study information about them. But if you go on to the next slide, we can see some of the early findings, and I suggest perhaps that some of these findings are a bit concerning. In some ways, if you know this sector, you won't be surprised by our findings, but I think they illustrate the urgency with which we need to find better ways of giving support to people who are self-employed in the construction sector. So on this first slide, I won't read out the small detail of the graph for you. We use the GAD-7, which is again a standardized measure of measuring anxiety. We found in the whole population that we've surveyed that about a third have GAD scores which put them in the severe anxiety scale. So these are people at risk of having, quite clinically serious anxiety problems. And we asked them what the main sources or causes of stress and anxiety were, and the top answers were around workload and work pressure, and their colleagues and their business partners, family issues and financial pressures, and for some of them COVID issues. That was either direct concern about their own health or the health of their family members, but also collateral issues such as interruptions in the supply of building materials and so on caused by the pandemic. So many of these pressures are weighing quite heavily on people, and of course the scores on some of these were particularly high amongst those people reporting severe anxiety. If you go to the next slide, we can see how some of this low mood and anxiety has affected behaviour. And so we asked people, what did you do when you found you're experiencing low mood in the last 6 months? The top answers were thinking about quitting or changing jobs. Significant proportion of people saying that they were consuming more alcohol or non-prescription drugs. Many people reporting irritability with either colleagues or family members. Less than 20% are seeking support directly from their GP, which is a real concern. And perhaps more worryingly, the same percentage of people who said that they considered self-harm was also seeking counselling. So, in a sense, you've got a group here who are torn between getting support through counselling or considering self-harm, and it's a real concern that that's such a high level of quite an extreme response to having high levels of anxiety. And this is a group where we need to really accelerate our efforts to get support that's accessible and which they're likely to use. If you go to the next slide, I've picked out some of the challenges that I think that this survey so far is highlighting. That anxiety is a very prevalent issue in this particular workforce. So I think what we can see here is that even the autonomy that on the face of it people have, it's being outweighed by some of the other sources of anxiety and low mood that we're seeing in this population. There's also quite a high level of mental health stigma and reluctance to get support, and that means it's actually quite hard to target interventions that will support these people. As we've seen, there's an elevated risk of adopting unhealthy behaviours and even self-harm. That some of the conventional sources of support that you might imagine would be the most accessible and reliable are not really that well regarded. Although we have asked about what sorts of support people might use in the future, trade bodies, charity resources might have more impact. Social media has got relatively low support for that as ways of getting hold of people. So we need to be a lot more imaginative about how we do that. And we're certainly discussing with our colleagues in Mates in Mind how we frame some recommendations from this research to try and improve the situation. And we also think that education, risk assessment, prevention, peer support should play at least as much a part in this as crisis management. We need to go upstream rather than just focusing on picking people up once they fall over. Doing more at the front end to prevent this becoming a problem is something we need to focus on. So you'll hear more about this in the coming weeks. This is a really important study and is shedding some light on a really important and sometimes neglected group. What I'd also just say just before I close is that COVID-19 has emphasised to many businesses that workforce health is a business critical issue which affects business continuity and productivity. So I'd just like to finish with a few thoughts about how employers can do more to promote well-being at work, given what we now know about the links between job quality and workforce health. Let's go to the next slide, please. I was lucky enough for 5 or 6 years to be a judge at the Global Healthy Workplace Awards, which meant that I saw really high-level practice from a number of organisations, not just big multinationals, but SMEs and middle-sized organisations, not just from the UK, but North America, Africa, South America, Australia, and so on. So I've tried to sort of distill down some of the things that I think are important from what I've seen, at least in terms of employer practices in this area. I think sometimes I would say that organisations have divided their attention a little bit and perhaps have lost focus on what they really ought to be focused, how they ought to be investing and directing their efforts. I think sometimes we focus on patching people up and getting them back to work as soon as possible, which of course is a good thing, but perhaps ignore or understate the role that risk assessment and prevention can play. I think this is one of the areas where the well-being part of the occupational safety and health and well-being debate needs to sort of work more closely together. I think that there are good disciplines in traditional occupational safety and health management in terms of risk assessment and prevention, which are as relevant to the wider well-being issue and particularly mental health. I think we need to be adopting some practices that learn from those disciplines. I think we have a tendency sometimes to over-medicalise some of these health issues, and indeed what some of the solutions are. And we need to be clear whether we're talking about mortality or risk of mortality. We're probably not doing that so much in employing organisations, apart from the very safety critical ones. But morbidity, well-being, wellness, and so on. We need to define really what our terms are and what we're focusing on, what we're trying to improve. I think sometimes we focus more on the symptoms rather than on the causes, and therefore on prevention. I think getting under the skin of what's causing some of these problems for people, and to what extent it's the way that we organise work or the way we manage people or the quality of management is a really important part of this. And sometimes we go straight to trying to resolve the problem because of the symptoms, and then we're surprised that the problem comes back. We don't also focus very much on self-management by workers with health conditions. We're at risk of doing things to people rather than with them. We know from some other research that people who have a say in the way that their health conditions are managed at work and that's certainly the case with the piece of research we published last week on return to work after cancer, usually have better outcomes in terms of sustained return to work, job retention, and improving productivity, as well as their morale and motivation, of course. Go to the next slide, just a continuation of this list. I think sometimes we fall into the trap of taking a deficit-based view rather than a capability-based view about well-being at work. We see well-being or poor health as a burden rather than good health as being an appreciating asset that requires some stewardship from HR and OSH professionals. It's rare to find many good examples in organisations of coordinated early intervention, vocational rehabilitation practices that involve line managers, good job redesign. Obviously, the Equalities Act requires this to be the case for people with protected characteristics, but it's good practice anyway, and I think I'd like to see a bit more joined up practice in those areas. I think it's pretty clear, as Dr. Paul Litchfield, former Chief Medical Officer of BT, said, that fruit and Pilates evangelism often gets in the way of promoting good work. And I think one of the challenges we have here is that fruit bowls and gym membership are really no substitute for a positive culture, good leadership, positive psychosocial health, good job design, and good vocational rehabilitation. And I've got some further comments to make on that in the next slide. I think we need to accept that in some organisations, the business case can crowd out the moral case for improving well-being at work. We spoke to a senior manager in a large organisation during the lockdown who said he thought that job stress was a better driver of productivity than any well-being programme. And so it's still the case that some people have got some perhaps unreconstructed attitudes to this issue, and they believe that putting people under pressure is a better way of getting them to perform than looking after them. So we need to tackle that, I think. I also make some points about evaluation. I think too often we measure how many people participate in a health intervention rather than how their health is actually affected. And that comes back to this question about whether or not we review health as a risk or as an asset. Go to the next slide, please. One issue I think that we have is that we need to confront is whether our wellbeing practices are perks or interventions. Obviously, we're in a very tight labour market at the moment, lots of skill shortages and recruitment difficulties and so on. We just need to be honest, really authentic about whether or not what we're trying to do here. I just worry sometimes that if we pretend that health benefits are the same as health interventions, and they're not. And both are legitimate things to do, obviously, but it does affect where we invest and how we judge our success. And I just think we need to be really clear whether or not we're really just trying to attract people in the labour market or really genuinely and sustainably affect their well-being at work. There are other aspects of improving practice. On the next slide, please. So we need organisations to have a clear philosophy about workforce health that leads to clear objectives. I still don't think we've cracked that one. We need evidence-based practices that benefit both the company and employees. And I think too few practices that employers are using are evidence-based. We need risk assessment and prevention, not just patching people up and accelerating return to work. We need to resolve this perk or health intervention question. We need much more employee involvement in all this and better support and education for line managers. We don't want line managers to be clinical psychologists, but we need them to be intelligent and compassionate and signpost people to support. And then we need to evaluate, reflect and improve. Actually at IES we've established recently a trials unit which is trying to work with employers to measure the impact of their interventions and to do so in a robust way. So what I'd say in conclusion is that the mantra that good work is an essential part of good work, is good health for people of working age has got considerable scientific support both at a population or epidemiological level and in workplace settings. And for employers, the challenge is to find a mix of evidence-based practices which help them to prevent ill health and injury, to promote well-being and to support vocational rehabilitation, functional restoration and recovery. And it's especially important as we confront new challenges such as the health impact of an ageing workforce and the as yet really unknown and uncharted consequences of long COVID on people's ability to remain active at work and to come back effectively at work. Next slide, please. As Steve mentioned, the new book, I mean, one of the things that Carrie Cooper and I did in writing this book was try and get a focus much more on how the health of the working age population can really enhance the productive capacity of the UK workforce. And I think that we'll really fall short if we don't pay sufficient attention to health, safety and well-being as what we call the third factor of production beyond investing in technology and investing in skills. And given that's a really important part of the government's agenda, we think we need to elevate workforce health as that third factor of production. Thank you very much indeed for your attention. I'm very happy to take any questions.
Thank you, Stephen. Really interesting and very detailed, and thank you for a very valuable presentation there. Just to take you back to the start, actually, you began by setting out, if you like, the impact on our mortality of social standing and class, and in fact inequality. How far can we expect work to actually turn that around, and how long does that take, do you think? I know that's a sort of a large question here, but it's the sort of sense of scale here in terms of how far work can help, I guess, in these issues. What are we talking here? How big a difference?
It's an absolutely very good question. I mean, I think the people I'm working with at the Centre for Musculoskeletal Health and Work at Southampton University are part of what's called the Life Course Epidemiology Unit. And I suppose that gives you a clue to part of the answer that we really are talking long term here. It's taken a long time for us to get to the situation we are in now, where we've had rising life expectancy over decades. Michael Marmot's work suggests that for some groups, the growth in life expectancy has slowed down, in some cases has reversed. And he points to all those social determinants of health as being contributory factors. So employment is just one of them. I mean, I would say that, whilst I think the argument about, for example, precarious work and gig work is sometimes overstated, it's still only 4 or 5% of the total workforce. There is evidence that those people who work in more precarious jobs are more detached, more distant from the sort of standard model of employment, permanent work, full-time work, and so on, tend, in the early evidence at least, to have worse mental health. And I suppose what I would argue is that there are some things that are happening in the wider labour market as well as in workplaces that are likely to exacerbate existing inequalities. And we've seen that a little bit with the pandemic. And I think that these things do happen over a long time. In terms of what role employment plays across all the different social determinants of health, I'd say it's relatively small compared with things like education and housing and air quality and so on. But if you're into public health, and looking at what can be done, clearly, if people are in poor quality jobs, particularly where the sort of psychosocial quality of the jobs that they're doing is poor, in some cases that can be worse for your health than being unemployed. And there's pretty good evidence of that from the psychiatric morbidity surveys and so on. So I think we can do quite a bit by giving people access to good quality jobs as far as possible, to try to help elevate them out of poverty, help to correct some of the issues that occurred to them in an education system which is still riddled with inequality. We shouldn't have too many expectations in the grand scheme of things of employment can do these things by itself, but as part of a coordinated strategy, I think it can make a big difference.
Okay, thank you. And I was interested in your comments towards the end then about sort of the contribution this could make to levelling up and the government's agenda now. And someone on our question pane has asked, they noticed around the Olympics that when that was being held, there seemed to be a benefit to quality of life, if you like, and also potentially, and I don't know if this is true, but lower life expectancy in East London after that compared to West London. That may be the case. And if that gap was better at that point, do you think that's got worse again? And what's any thoughts around the sort of impact that projects like that and work, if you like, in that sense can have?
Yeah, I think that's true. I think, again, I'd rely quite a bit on the report that Michael Marmot produced just literally a couple of weeks before the first lockdown in February, I think it was 2020, where he revisited his social determinants of health research in the UK. And I mean, some of the things he looked at in his study were, what the levels of investment were, spending in each local government area. What he found was that the biggest cuts in local government spending were in the poorest communities, certainly since 2010, since austerity started. So I think he draws a fairly clear connection between some of these aspects of public sector investment in local government and the support that local authorities can provide local communities, and some of these health outcomes and widening inequalities. And it's hard to get into that discussion without sounding as if you're being political, but I think what Marmot suggests is that that's what the evidence says, and that leads policymakers to some practical choices about what they do about it. It wouldn't surprise me if in some parts of the East End of London, around the Olympic Park and so on, particularly given the legacy developments in housing and office space and so on, that we won't have seen some narrowing of some inequalities in some communities. But because this is so vulnerable to fluctuations in funding and investment and so on, to coin a phrase, these things can go up as well as down. And I think what Marmot is trying to do is to get policymakers to understand that there are unintended consequences sometimes of choices they make at a national level, and that really needs to inform the levelling up debate and discussion. And I think a lot of people are gratified that that understanding seems to be reflected in the levelling up white paper. But there's a big gap between the rhetoric of a white paper and the practice on the ground. So it remains to be seen how that works in practice.
Yeah, and I'm glad you mentioned Marmot, because someone's asked actually about the Whitehall 2 study being some time ago now. I think it was conducted quite a while ago. So how are things on that study different now, if at all, do you think? The one you showed, the Whitehall 2 study, wasn't it? It was called, I think.
Yeah, that's right. I mean, there have been a few follow-up studies as well. The first study was done started in the 60s, I think, and was done only looking at male civil servants, which probably tells you something about the way we frame research questions in that time. Whitehall 2 study included still only about 35–40% were women, I think. So I think there's been a change in the sampling. I think also the subsequent research has also looked at things like health in the ageing workforce as well. I don't think the fundamentals have changed very much. I think that core principle that there are aspects of the intrinsic quality of the jobs that you do and health outcomes which are strongly related to each other and can't be explained by whether people are smokers or whether they're got bad diets and so on. There is something fairly irreducible about the content of the jobs you do, how your work is organised, your place in the hierarchy in an organisation, and it does come back to all those issues around control and autonomy and discretion and variety and challenge. What makes for a good job? Enjoyable, fulfilling job that gives you an animating purpose. Now, there's a lot of rhetoric in the HR community about that, because that's what engages people, and that's what chief execs want of their staff. They want them to come to work and give discretionary effort. Now, if we believe all that, and we want people to perform sustainably well and produce added value performance for their organisations, then it's quite hard for me, at least, to see intellectually, and in terms of what the data says, how you can separate good work as a driver of performance and productivity and good work as a driver of health and well-being, because those two things are intimately linked together. And this is not just about reducing sickness absence, it's allowing people to thrive and flourish at work.
And actually, just a sort of a specific question someone's got on the Whitehall, I guess, and other sort of studies like it. Do you know if this sort of thing has ever been done in call centres, just out of interest, in terms of jobs? It's quite specific.
I don't know whether, from a sort of an epidemiological point of view, but actually in my last job when I was at the Work Foundation, we published a report called Constrained Work, which basically asked the question, are there some jobs that are just beyond enriching? Are there some jobs that are so boring and routine and fragmented that you can't make them any more interesting? And we looked at call centre jobs as part of that piece of work. So if you can find it, although the Work Foundation, I think, has taken a lot of its research off its website since I left, not because I left, but it's a report which I co-authored called Constrained Work. I do have a copy, so if people are interested in it, they can drop me a line and I can send it to them. I can send it to you to send out, but it does look at call centres specifically. And the answer is, don't despair. You know, call centres can be the drivers of job enrichment and good quality work as well.
Interesting. Just turning to a different sector now, construction. So someone's actually said they're quite shocked by the statistics that you went through on construction and the industry as a whole, and that their organisation provides construction skills training, and asks you, what are the best sort of things that we can do as training providers, say, or indeed even providing trainers in organisations, I guess, to sort of help resilience, and particularly obviously with people going into the profession. But I guess another question might be, you know, how we actually encourage people in construction to help each other is another thing. Sort of, I wondered if you could say
yeah, that's really important. I mean, what I would definitely like to emphasise is that there's some absolutely amazing examples in the construction sector, particularly some of the large organisations who take this really seriously, are doing some fantastic work, are working with their supply chains, and so on. So this is, you know, we're not starting at zero construction. You know, we're focusing in this particular study in that group of self-employed construction workers, which and of course the data are shocking, and I think that, you know, the large construction companies recognise they do play a part in this, and I would praise them, because most of them are doing brilliant work in this area, and they're as concerned as we are about this, I think. I mean, I think that there are still more things that can be done. I mean, one of the issues, you know, in the Royal Mail a few years ago, for example, they were experiencing 3 to 5 suicides a month. Now, you can either be concerned about that because it's something that the organisation is doing that elevates the risk of suicide, or you could say for relatively young, relatively unskilled male workers as a population, that's the level of suicide you'd expect, just as in the population. And this is one of the things that's really hard to untangle. How much of it is the responsibility or caused by the work itself or the work environment? How much is it because that's the ambient level of distress, mental distress in that population? I think employers need to discharge their duty of care, of course, and go beyond that if at all possible by putting steps in place that can prevent that. And I think we do have an issue, particularly amongst men, but not exclusively, that their willingness to disclose that they're struggling in terms of their mental health is often quite poor. There is definitely still a stigma about it, and admitting it to your co-workers or even to family members can be incredibly difficult. And also there's this sense that, you know, if you do disclose that you're flaky or unreliable or you've admitted defeat and so on. Now, I think, you know, the conversations that we see happening in football and rugby and cricket and, you know, in the wider public discourse about the acceptability of talking about mental health are really good. And I think hopefully should encourage more, particularly young men, or indeed middle-aged men, to talk about this, but, you know, should spread over the whole of the population, so that we all, in general, are much more comfortable talking about our mental well-being, and recognising that, you know, 1 in 4 of us through our lifetime will have some sort of episode of depression or anxiety.
Well, Stephen, I know we've got further questions, but I think we're out of time. I'm going to say a big thank you to you, and a really fantastic session. So thank you so much. And we obviously wish you all the best as well with your continued recovery, and wish you well. So thank you very much. And next we'll be hearing from Irfan Arif about psychological safety and inclusion. So as always, this session will now close, but do please join by coming back to the GoToEvent homepage and clicking on the next session when it goes blue, and we'll see you in a minute or two. Thank you.